Thank you. Thank you, Dr. Amit.
Morning. Good morning,
Morning,
Doctor.
sir.
Hi, Abhijit. Dr. Divya.
Hello,
Hello,
sir.
Dr.
sir.
Manga.
Hi, sir.
Uh,
Good morning.
Dr. Ramesh ki presence is has both very calming effect and also
क्या बोल रहे हैं?
takes me through a long journey we have had together.
Yeah, absolutely. 25 years now.
Yep.
Good morning, Dr. Gowda.
Good morning, sir.
So we would not be able to see audience here.
No, you will not be able to see them. The questions will also come in the chat box. You will be only seeing us.
Okay. So
Yes.
I asked Dr. Deepika and Dr. Satya to join because Deepika is the first author and Dr. Satya is the second author. So they may have some valuable inputs to provide. So you can find a way how to do that. I'm not too sure whether they are there. They've joined as yet or not. Is there any way to know?
Have you sent them viewers link or panelist link?
I have sent the one that Dr. Pooja has sent to me.
That's the panelist link.
That's okay.
Dr.
Deepika is-
Deepika has joined. Dr. Deepika is there.
Hi, Deepika. Good morning.
Dr. Deepika, can you hear us? Hi, good morning to you.
Good morning, ma'am. Yes, ma'am. I'm able to hear you.
Good morning, Doctor.
Welcome.
In the end, it will be a good idea to have a common when all the videos are or with all the participants, then having a group photograph can be something which can also be done.
Normally, I think the screenshots are there
Yes,
intermittently.
Screenshot, yeah. So most of the
We'll be going
DIEP
live in
person-
another minute, I think. in
Yeah, so before that,
9:59.
if DIEP people
we
can
are
do
live.
that. Okay.
But
We are already
recording
live.
will be started at 10 p.m. 10 a.m. So
So I'll start the thing.
You can start, Dr. Pooja. Yeah.
So, good morning to all. So good morning to all the viewers and the panelists. I welcome you all to this Journal Ki Baat. So today we'll be discussing the important articles from the July issue of Indian Pediatrics. And it's my proud privilege to welcome Professor Ramesh Agarwal. He's a well-known neonatologist from AIIMS, Delhi. We also have with us Dr. Mandar from Mumbai. He's also a pediatric intensivist. So welcome, Dr. Mandar. We also have Dr. Mamta Gowda with us. She is another author for one of the review articles in this issue. We have Dr. Deepika Kent, who's also from AIIMS Delhi. And Dr. Divya is our PG student participant for this show, and she's from Manipal, KMC Manipal. So welcome to all of you. And now I hand over the proceedings to Dr. Abhijit.
So first article, Dr. Amit. Hand
Okay.
over to Dr. Amit. Yeah.
Okay. So the first article is a core neonatology article and done by a team led by Dr. Ramesh Agarwal at AIIMS New Delhi. And they evaluated a very pertinent, debatable, hot topic today for pediatricians dealing with very low birth weight babies specifically, was use of paracetamol for treatment of patent ductus arteriosus in preterm neonates. It was a retrospective 5-year experience from their unit, and they included all preterm babies, did functional echo, and based on the functional echo, they decided to treat certain babies. And Dr. Ramesh Agarwal will tell us the outcome of such treated babies and what complications did they face and what was the success rate of treatment with this very benign, commonly used drug, paracetamol, which has recently come into picture because most of the other drugs which we use had significant side effects. and were not readily available in India, like indomethacin and IV brufen. So it's a very India-centric, a new old drug with a new use. Over to you, Dr. Ramesh.
Thank you, and good morning to everyone, the panelists, the participants, and I learned from Dr. Amit that it's a large gathering. So thanks, Dr. Diwan and Dr. Shah and Dr. Amit for providing this opportunity and to learn from this audience gathering. So my plan is, to just tell the salient aspects of this paper, the retrospective study that has recently been published. And with us, we have Dr. Deepika, who is a faculty colleague at AIIMS, and Dr. Satya, who has just completed his DM neonatology and joined. He is a co-author. So I'll ask them to add if there is anything else that is relevant to this context. And I would request them to be very brief, and so would I be. So kindly allow me to share the screen. Yeah. Is it visible on the screen, Dr. Pooja?
Yes.
Yes.
Okay. So this is the title of the study is use of paracetamol for the treatment of PDA in preterm neonates, a 5-year experience from a tertiary care hospital in India. So the objective of this study was to share our experience of using this drug on its efficacy and short-term adverse effects, including morbidity and mortality. This was a single center study undertaken at AIIMS, New Delhi. We included all inborn neonates that were less than 37 weeks of gestation with hemodynamically significant PDA and that were born between 2017 and 2021. Total of 5 years of period. And those who have been diagnosed with hemodynamic significant PDA plus received paracetamol therapy as the first line drug. So these were the neonates that were included in the study. And primary outcome was the closure rate. And the secondary outcomes were need for repeat pharmacotherapy, need for surgical ligation, need, the onset of pulmonary hypertension, new onset of pulmonary hypertension after paracetamol treatment, and in hospital morbidity and mortality. During this period, we had in-house echocardiography, and using a protocol-based approach, we screened them. And I'll let you know when do we do that. And we define hemodynamically significant PDA as ductus diameter more than 1.5 mm and left atrium to aortic root ratio as more than 1.4. And the echocardiography is done by the fellow, the DM student, and often confirmed by a faculty. So during this period, this is what we done. If the infant was less than or equal to 28 weeks, we screen them and we treat them using an early targeted approach. And that means you will screen the baby, and if they meet the criteria and even if the symptoms were not there, then we will treat them. The baby is a little bigger, that is those between 29 and 30 weeks. We screen them, but less often. And again, if the hemodynamic HSPDA is there, then we will treat them. And the bigger neonates, that means 31 to 36 weeks, if there are any symptoms, then we will do echocardiography. So HSPDA plus symptoms would only mandate the treatment. This is the flow chart. During this 5 years period, we had a total of 2784 neonates, and of them, 117 were diagnosed with HSPDA, incidence being approximately 5 to 6%. So it's a low incidence. And of them, 16 had pulmonary hypertension. So therefore, they were not treated because that's a contraindication for treatment of HSPDA. And we treated 101 of them. One required surgical ligation and 100 required pharmacotherapy. 4 received ibuprofen and 96 received PCM. And during the course of treatment, 20 neonates died, mainly because of sepsis, 5 because of PDA, and then 4 other because of 2 pulmonary hypertension and 2 IVs. So of 96 babies, 20 died and 76 completed the first course of PCM. And of these 76 babies, 43 achieved PDA closure, 33 did not. And of these 33 neonates, 5 had pulmonary hypertension. And in 28, we decided to do repeat therapy. And of these, 14 received PCM and 14 received ibuprofen. And there is those receiving PCM, 10 achieved PDA closure and 4 did not. And 2 of them underwent ligation. And the 14 who received ibuprofen, 2 received PDA closure and 12 did not, and 6 of them underwent PDA ligation. Looking at the baseline characteristics, these were essentially small babies. In fact, 40% of them being less than 28 weeks. Another 50% between 28 and 31 weeks. 32 weeks and bigger were only a minority, signifying the fact that in a tertiary care unit, the PDA was largely a problem of babies who are less than 32 weeks. The complete course of antenatal steroids was received in approximately half of the babies. 60% received surfactant, and half of these babies were on invasive ventilation, signifying that these were essentially sick babies. And approximately 13% of them developed culture positive sepsis, often early onset, but some of them may be late onset sepsis also. So looking at the outcomes, the successful PDA closure after the first course was present in 56.6% cases. That means approximately half of such babies, and this was most often, IV therapy. Some of them did receive oral treatment also. So approximately half of them had closure. Another 40% approximately required repeat pharmacotherapy. And 8 of 76 babies, approximately 10% of them needed surgical ligation. So I'll repeat these findings again once. Successful closure after PDA PDA closure after successful after the first course of treatment, after first course of paracetamol, was there in 56.6% cases. 36.8% required repeat therapy because it did not close. 10% required surgical ligation. Of all the cohort of 96 babies, there were 43 deaths. Nearly 60% of them were because of sepsis. These were small neonates staying for a very long time in the NICU with a median stay of 67 days. Pulmonary hemorrhage was not a major problem. Pulmonary hypertension after treatment was present in approximately 5.2% cases. 1/3 of them had any grade of PPD, often mild to moderate. Some of them were severe. ROP requiring laser was present in 10% of the cases. NEC, again, any stage was there in only 5% of the babies, and few of them had the severe grade of NEC also. Similarly, IVH and PVL were present in 1/4 to 1/3 of the cases, often, the milder degree. And persistent PDA discharge was present in 5% of the cases. So the points that we wish to make are, one, that approximately 60% of the babies would have PDA closure by use of IV or oral paracetamol. That's one. Two, that it's in general a well-tolerated drug. Despite being very sick and small babies, I think we didn't encounter any major problem. In fact, that was the reason how the paracetamol has made its way in our practice, that the side effects were very low. The literature cautioned that the PCM might be associated with pulmonary hypertension, and that concern was there in our mind. So therefore, before treatment, we would screen and then see whether pulmonary hypertension is there or not there. And if it is there, then it's a contraindication for the treatment of PDA. But during the course of therapy also, we looked at it, and we found that 5 of them actually had pulmonary hypertension. So, this is just a finding. It might mean that the paracetamol is triggering pulmonary hypertension, or it may be just an association. We don't have any control group in this for this cohort. So therefore, the establishing causal relationship, and what I mean by that we cannot say that paracetamol led to pulmonary hypertension. We can only say that 5% of the babies had development of pulmonary hypertension. So in conclusion, it's a moderately effective drug with pretty high safety profile, and be cautious about the development of pulmonary hypertension. I stop there, and before making a few more comments those can come while we are discussing, and would request Dr. Deepika and Dr. Satya if they have any more points. Can you be brief?
Thank you, sir. Am I audible?
Yes.
Yep.
Sir, so I think sir summarized the essence of the paper very nicely. And all the points I think were important when we were designing the study, because we felt that PCM is safe in the unit. That is why we are using it. And now we have data to say that, okay, PCM is actually safe. And the only concern that we wanted to highlight in the study was this development of pulmonary hypertension, which is mostly unknown till now. So that some anecdotal evidence says that pulmonary hypertension can be associated with any treatment for PDA, because what PDA closure typically can mean is the increase in right-sided pressures, and ultimately the shunt would reverse. So that can happen with any drug, but it has been shown in some reports that PCM is the drug that is mostly implicated as compared to ibuprofen or other NSAIDs. So it is not that only PCM causes this. There are some reports that say that ibuprofen also causes that pulmonary hypertension, and other NSAIDs also cause that pulmonary hypertension. But because we are pro PCM, we can say, so PCM safety, we need to be very, very sure that PCM is a safe drug. And because pulmonary hypertension being a deadly disease in a very preterm or an extreme preterm unit, we need to be very cautious about it. And we might not be evaluating evolution of pulmonary hypertension. So I think apart from the confidence that we have is okay, 60% we are able to close by the first course, and additional maybe by 70% we are able to reach with the second course of PCM. I think we need to be cautious. The one thing that we came out of this paper is that, okay, we need to be worried about this pulmonary hypertension, which might be occurring because of PCM, and the further studies should evaluate this cause. Sir, I close here.
Okay. Thank you, Dr. Ramesh and Dr. Kat, Dr. Deepika. So a wonderful study. It tries to answer a very pertinent question. And what was very heartening to know is despite giving orally, and efficacy was as good as with the IV. So, Dr. Ramesh, which patients got it orally? Was it based on who is tolerating feeds gets orally, and who is still nil orally for whatever reason gets IV? Can you hear?
No. Yeah, so it is based on whether the babies were tolerating any enteral feeding or not. If they were, then the oral paracetamol was our choice. If not, and majority of them were not, then IV is the choice.
Okay.
In fact, this was one of the reasons that pushed us to use paracetamol. So, better safety profile, availability of a cheap drug, because indomethacin was not available or available at higher cost, and Brimphen IV is not available. And apart from that, everyone is concerned about renal and GI toxicity, and that made us to use paracetamol.
Wonderful. And another thing was regarding the definition of hemodynamically significant PDA. So hemodynamically was based on certain echo parameters. So was symptomatology also used as a marker of saying it is hemodynamically significant? Whereas, like, suppose if there is a baby who is not having any significant distress on CPAP, he is relatively okay. We do a echo at 36 hours, and we find that his LA aortic ratio is this much, and the ductal diameter is this much. We went on to treat such a baby who, if we would not have done echo, we might not have treated, considering that he's only on CPAP and also tolerating feeds. So down, like, this study was started in 2018, I suppose, or 19. Was it 17? When was it started?
17 to 21.
17. So after 7 years, would you still go for treating asymptomatic babies who have certain echo parameters which are positive, or do you think in today's era we would just wait and follow these babies for their course and then decide to treat later on?
Yeah, so first is that study period was 17 to 21. So it's almost 3 years, even for the last baby that we had enrolled. So that was the period when there was a lot of emphasis on screening and early targeted treatment. And because these were small babies, and sort of consensus was that you screen small babies, those who are less than 28 weeks, and do the early targeted treatment, screen them. And if you find echocardiographic, HSPDA by echo, then you treat it. Bigger baby, it was meaning 28 and bigger, largely it's symptomatic baby. So you have symptoms, you do echo, and you find HSPDA, then you treat it, otherwise not. It seems now with more evidence, people feel that a couple of large trials, people feel that there is no need for screening, and look for the symptoms. And if there are symptoms and you find HSPDA by echocardiography, then you treat. But the bottom line is yet to be said. In general, what we can say, the people are moving from aggressive approach to PDA to a more conservative approach to
More
PDA.
conservative approach in treatment, yes. So the verdict is still not out, and it's still open to debate. That's what we can say. The interesting thing was the duration of treatment of only 3 days. So, and then we had to repeat it in almost 50% of our babies. So many would have gone, 44% would not close. So do you think now that probably a longer course, so you would have started retreatment on 4th day? If on 3rd day the drug is, the PDA is still open, then, and so did you look at symptoms at that time, or just drug closure was the primary thing? So he was on ventilator initially, now he's probably extubated, or was on CPAP and now he's extubated. So what was the endpoint for repeat course? Was it still echocardiographic evidence only, or clinical hemodynamic significance was also looked at?
Yeah, that's a good question, Amit. And this being a retrospective study, and the retrospective study would always have information bias. And what is the meaning of that is that we have no way to find, how that baby was treated. So you have records, but I'm quite sure record would not precisely reflect what was thinking at that point in time. But in general, our approach is that you have a PDA, assess the baby in terms of symptoms, and assess the babies in terms of echocardiography. So
Okay.
if you have HSPDA and you think that the symptoms are also there, or in a very small baby, HSPDA only even without symptoms, then that would warrant for repeat course. Whether you go for PCM or you go for paracetamol has dependent
Brutal.
on many factors, whether the baby was small, sick, other comorbidities, etc.
Okay. Okay. So was search there was I was intrigued by about almost 10% babies requiring ligation, which seems to be a bit higher than what most of us see. So even at these low gestations. So can you tell us, like, in the beginning, were there any predictors based on your data of which babies are more likely to be ligated, or failure of full even two courses of therapy? Because such babies are, if we can know them earlier, then centers who do not have facility for ligation, they can think of early referral as well.
No,
Okay.
we don't have predictors, but the impression that we carry is that if the baby is of smaller gestation and with a lot of comorbidities, then these are the babies who tend to have persistence of PDA. And as you can see that the ligation has been done much later. So you try all the
What was the
measures.
average age at ligation?
Age at ligation, do we have Deepika data? Age at ligation, need for PD ligation was there in 8 of 76. At least it is not mentioned here. Deepika, do you have data? No,
Sir, I
you
have. I'll just pull it out in a minute.
okay, right. So often, it would be second, third, or even fourth week.
Okay.
Getting them to have surgical closure would require a lot of things, including getting cardiology on team, CTBS on team, OT, distance, stability of baby.
And ligation is done
And all that.
in the unit itself, or he's taken to a cardiac center and there the ligation is done. That would be
No,
important.
we will take them to CN center and do it there. And many of them actually, we have done device closure, I guess. Or we did device closure later. Deepika, do we have
Yes,
data?
sir. So
Yeah.
we did not do device closure for this cohort. It was started
Okay.
in 2022, as far as I remember. Maybe one odd baby would have been there, but these babies were all ligated, and none of them had device closure. And the median age was 31 days with the IQR of 28 to 57 days.
Right.
Yes, sir.
Now,
31 days,
in
1 month of age.
last 3-4 years, we have largely shifted to device closure than ligation.
Okay. One thing which intrigues me is in the table 3, which you had shown, Dr. Ramesh, overall deaths. So overall deaths, it says 43 out of 96, which is 44.7%. So this 44.7% seems to be, so is this data right? Like 44% mortality in babies who are between 26 and 27 weeks to 30 weeks or so. Is it so?
Yeah, I think the data is correct. So I think we need to first understand that this is an inborn cohort without any selection bias. Each and every baby has been accounted for. Secondly, that this exclude all the babies that were stable. These are sick babies, and primarily babies who are less than 31 weeks and sick, half of them being ventilated. Therefore, the high mortality. And if you look at the unselected cohort, then ones that are stable as well as those with morbidities, I think we would have a survival for less than 28 weeks as approximately 60%. And the ones that are 29, 30 approximately 70%, and 31 approximately 80%.
So I think that's a very important message for the practitioners who are uh, attending this webinar is we need, often patients ask us, sir, ठीक हो जाएगा कि नहीं आएगा? After every full counseling, their one line question is, will my baby be okay or not? I'm not interested in whatever you have told me else. So this data of about 50% mortality for very preterm can be emphasized, and that can be a good number to say that under 30 weeks, who has significant morbidities, up to 50% may not survive at even best of the centers. So one message for practitioners could be this: not to be, very disturbed about a baby who is very well. We just have to tell the parents properly. Another one last query to you, Dr. Ramesh, is in the discussion part, it is in the result part, it is said oral route significantly increase odds of PDA closure with the odds ratio of 4.9. It was, so is it compared to IV route or is it compared to no treatment? And
Can you respond?
Yes, sir.
Oral routes significantly increase the odds of PDA closure.
Yes.
Oral
So
route
like-
significantly increase odds of PDA closure, whereas
So-
the data doesn't suggest that oral and IV are two different. Your table 3, line second and third, successful closure of IV PCM is 56%, closure of oral is 57.9%. But here on a multivariate logistic regression, only oral route significantly so I didn't compare to what is not clear over here.
It is so because we don't have data for no treatment limb. So this is all related to IV actually, because no treatment we don't have. You have all the babies who were treated with PCM. So the comparator arm will be oral versus IV.
It doesn't.
No, Deepika, it must have been something else because odds ratio of 4.9 means that the comparative arm has to be something else. We will check it
We'll check again.
and get back on this, and maybe if you have any mechanism, then that information can be passed on to the audience.
Yes.
But
That's
I
fine.
think there is something else here, Deepika. It's not
Sir, I will
compared. It
check.
will be compared to IV because the closure rate is more or less the same in oral and IV.
Yep.
Yes, sir. I will check it, sir. And I will share with the audience, sir.
Thank you.
Yeah.
Whenever from practitioner's perspective, I had this query was like 3-day treatment versus 6-day treatment. When at 3 days, 46% are still 44% are still not closed. Then there is another school of thought which says about 6 to 7 days treatment of paracetamol. So would you now, after this study over a period of 7 years, you would still go for 3-day treatment or 6 or 7-day treatment because it's a relatively safe drug, less side effects are known till now. I have never as such felt my baby has developed PPHN after giving paracetamol. So what would you tell our audience that, okay, do we still stick to 3-day treatment, or if 44% failure rate is there, we can continue longer and we can have 70% success rate with 6-day treatment?
Deepika, would you like to respond?
Sir, I think we are still continuing to give a 3-day treatment. So even if we extend it to 6-day treatment, sir, I think in practice, we would still like to see whether it has closed by 3rd day or not. So because we will...
I mean, the short answer is that I'm not aware of continuous prolonged treatment for 6 days. So we do 3 days plus 3 days. So for those who are not closing, it's cumulatively 6 days, 6 days treatment, right? But in the first go, when you start treatment, and you think that instead of 12 doses over 3 days, I'll give 24 doses for 6 days. I think the evidence for that approach, I'm not aware of. It's possible that I may have missed, maybe Satya and Deepika can tell whether there is any study that has looked at 3 versus 6 days treatment by randomizing these babies. Because the ones that are not closing are different babies than the ones that are closing. So therefore, treating everyone with 6 days, because you still have 60% of the babies closing. So if as a primary intention you treat them for 24 doses over 6 days, then the 60% babies would get unnecessarily exposed. So while there may be merit, but we don't know the answer for sure, and we don't do it in our unit. We will do only after repeating echocardiogram.
So to add
Okay.
to your point, there is one study, one randomized control trial. There are no studies that compare day 3 versus day 6 because the recent Cochrane and the recent network meta-analysis also evaluated all the trials which are evaluating the efficacy of PCM. So there are no studies which actually said any particular day of treatment versus the other. But there was a study by Onsell in 2014, which actually said the limb for PCM treatment was for 5 days. So it was not 3 days. It was for 5 days. That was their limit policy. Sorry, sir. Was I clear?
Yeah.
Yeah. So there was a study which said that till day 5 the PCM was given. So there was a slightly extended course as compared to our course, but that the closure rate was also around 70% in the study.
Yeah. So we also use it currently for 6 days. We do a echo at 3 days. And if the PDA has closed, and if there is significant improvement in symptoms, we don't treat asymptomatic if there is HSPDA on day at 36 hours or whenever we have done echo. And if there is dilation, we don't treat if the baby is not significantly symptomatic. Non-invasive, we don't treat. I'm talking as a practitioner. So looking at side effects and also if the baby is tolerating feeds, and if the baby is on only CPAP and he just has echo findings which are significant, so we as of now we don't treat such babies and we just follow them. Despite the fact that earlier you treat, the better are the results of treatment. So if you start your paracetamol or brufen or whichever drug you're using on day second, third, then your likelihood of closure is more as opposed to if you think at 7 days the baby is now more symptomatic and you start treatment at 7 days. So that lacuna is there. But considering that 40% were not ventilated, we most often would not treat them now, 7 years later. And I think did steroid usage, you think prevented development of PDA because steroid has been shown to be PDA is not decreased was the initial understanding. Your study confirms the same effect of antenatal steroids on PDA.
So the question is whether the use of antenatal steroids
Yes.
have decreased the incidence of PDA. I'm not too sure on it. Whether it may have decreased the
Or
incidence.
closure rate, you looked at closure rates. So steroid group versus no steroid groups, any difference in closure?
No, sir. We did that analysis. There was no difference, sir.
Okay,
That's
thank
why it was
you.
not included in the multivariate regression models. Yes, sir.
Okay, thank you. So I would like to go to our postgraduate. We have one postgraduate as well with us. And have you been posted to NICU unit,
Yes, sir.
Dr. Divya?
Yes, sir. We have a special NICU unit. So we've been posted in that, sir. Yeah.
And do you see preterms of 28, 30 weeks surviving long? And do you have an echo machine which looks at PDA, if it is there or not?
Yes, sir. So we actually do get a lot of preterm babies, even like extreme preterms, even from 26 to 28 weeks, and a lot of very preterm babies also we get. And we do usually, so very like what we have generally noticed is when there's an extremely premature baby, and on day 1 of life usually gets ventilated, we give 1 dose of surfactant. The next day we get a screening echo. And if that shows a hemodynamically significant PDA and the child is also having, say, high oxygen requirement and signs of shock, if it is there, we do usually start the baby on paracetamol, like said, and we give it for 3 days. And on day 3, we do a repeat echo. And my doubt usually comes in this, sir, is that usually what we have seen is a PDA doesn't close. the baby continues to have shock and continues to have high oxygen requirement. It also has other complications, usually like NEC. We're not able to start feeds for the baby. This issue continues. And these kind of babies are usually very small, and we don't have a surgical ligation option in our center. So even after giving, say, 5 days of paracetamol, the period doesn't close and the clinical manifestations are still there. The
So,
biggest
Dr.
challenge
Divya,
comes.
I would like to interrupt at this point and just say that PDA as a cause of shock is not very common. So one has to look at other causes of shock in extreme preterms, which could be just improper fluid management. So it is at that point, it is important to look at all different causes of shock, whether is it low fluids which we are giving. So you need to have a more holistic view. At times we are get stuck at echo findings and is that PDA which is responsible for, because all these very preterm babies whom we are talking of, most often they have underfilling because we are not giving them enough humidification. We are not managing them with enough IV fluid. So looking at their electrolytes, their sodium, potassium, urine osmolarity may be another way to look at it rather than just concentrating on PDA. What do you say, Dr. Ramesh? Shock as a manifestation of
That's
PDA.
true. That's true. So, PDA, you
PDA
treat
at
that.
times is an innocent bystander which is blamed for many different murders. When it would say, "Oh my God, did I do something so bad?"
Fair enough. I think it's fair enough to say that. So therefore, when you are given a 1 dose of paracetamol for 3 days and you find now the baby has got many other morbidities, then you'll have to stop and then ask yourself, and with contraindication to many therapies that you are stating, right? So you have to stop and then ask, what is my priority? So, priority in the scenario that you described would be the management of shock and what has led to shock. And I would agree with Dr. Upadhyay that, the PDA as a cause of shock is not very common, right? We want to treat PDA primarily for the fact that one, occasional, baby can, simply burst into pulmonary hemorrhage and die. One. Two, for the prevention of bronchopulmonary dysplasia. Or necrotizing enterocolitis, right? Because ductal stealing might predispose the baby to necrotizing enterocolitis. Your baby already has necrotizing enterocolitis. So giving NSAIDs, how good that does to the baby, we really do not know. So I would treat shock and what has led to shock. And fluid deficit could be an important reason. Sepsis could be another reason. So I think addressing them would be more important.
Thank you, sir. Thank you very much. So we are pretty late. Over to, can we move on to Dr. Abhijit?
Yeah, sure.
That's our habit.
Thank
Late.
you, Dr. Huh?
That's our habit.
It was a very wonderful discussion.
And thank you, Dr. Pooja, Dr. Saha, and Dr. Amit for giving us this
Still not the
opportunity.
time to say thank you. Still we are there in the program, and please stay with us till the end. And
Okay.
just let's listen to Dr. Abhijit for the next paper.
Yeah.
Fair
So we know that good 5 to 10% of patients presenting to the ER, especially in the toddler age group, would have respiratory complaints and associated wheeze with them. So definitely there is a need for timely identification of high-risk wheezy children in the emergency to aid focused utilization of resources and also improve the outcomes. So this study is from University College of Medical Sciences and Associated GTB Hospital, New Delhi, where the authors conducted in the emergency and the intensive care unit. The title is SpO2, FiO2 and PeO2, FiO2 ratio for predicting intensive care admission in wheezy children, an observational study. And to talk about this study, we have Dr. Mandar from Mumbai. He is a pediatric intensivist, earlier in Vadia Hospital and now in MMA Hospital, Mumbai. So over to Dr. Mandar to discuss briefly the results and the implications of this study.
Yeah. Thank you, Dr. Abhijit, and good morning to everyone. I'll share my screen. Yeah, is it visible?
Yeah.
Yeah. Yeah. So we are going to discuss a study. This is considering the comparison or between the SF ratio and the PF ratio and their prediction of their intensive care admission in a children who has come to pediatric emergency in a wheezing state. So this was the observational study done at UCMS Delhi by Dr. Batra and team. And when it comes to wheezing in pediatric, this is not very uncommon, I will say, as the number says almost like 50% in up to their 6 years of age will face at least one episode of wheezing during their early 5 years or early 5 to 6 years of their life. And understanding those wheezing, whether they are going to need ICU or they're going to respond to the initial nebulization or initial intervention is also equally important. So what author has done here is they have tried to, the primary objective, what they have done is they have tried to determine the cutoff of the SF ratio, which is the ratio of your saturation and the FiO2, which is widely used in the pediatric intensive care setting when it comes to acute respiratory distress syndrome or acute lung injury, but they are not so frequently used in the pediatric emergency setting. So they have tried to extrapolate that ideology or that thought and concept, and then try to compare the or prediction of the SF ratio, the cutoff which was decided as less than 300 at hospital admission for predicting the ICU admission. That was the primary objective. And the secondary objective was to determine that sensitivity of PF, that is PaO2, which comes in your ABG, the PF ratio of less than 200, predicting the admission to the ICU. They also have studied the in-hospital mortality of these ratios and tried to correlate the both SF and PF ratios together. So those children who have come to pediatric emergency, aging between 6 months to 12 years, were included in the study. But the exclusion part was the children with underlying structural heart disease or lung disease, any children who comes with wheezing with suspected or the foreign body aspiration, any child who is very sick, like less than 80% saturation or more than 97% who are very stable, they excluded, as well as the congestive heart failure, they also have a wheezing. So those that cohort was excluded. And after the initial intervention of giving levosalbutamol or salbutamol nebulization, if they respond after the 3 dosages and they improve and they send home, those were also excluded from the category. And at admission, the saturation was measured. FiO2 was recorded on how much FiO2 was started. And after half an hour, the ABG was corrected and to get the PaO2 value. So the results were, so they actually enrolled 315 children, out of which 37, almost 12% require the admission in the PICU and 278 were transferred to the pediatric ward. The majority of children in this cohort who came to ER with wheezing were of the wheeze associated lower respiratory infection, almost 60% of them. The next followed by asthma and the bronchiolitis. Among 315, the 8 patients expired out of total, and out of which 7 was admitted to the PICU. So this is the table one which tells you the demographic data. So almost, though the age group was 6 months to 12 years, but if you can see, majority of the population is within 5 years. At 6 months to 1 year, they are 118, and in the 1 to 5 year, almost 157. So very few who comes who are called as late wheezers beyond 6 years of age. There are only 40 patients out of 350. And the proportion of children with SF ratio less than 300 was significantly higher, and those who were admitted to the PIC. So their statistical analysis showed that SF ratio less than 300 had a sensitivity of almost 97.3%, which is a very truly positive good number, but specificity of 16% for predicting the PICU admission. While the PF ratio, when the cutoff of use as less than 200, had a sensitivity of 62% and specificity of 94.6%. And they found a moderate level of linear correlation between the SF and PF ratio. So coming to the discussion part, so SF ratio, if you utilize it, it is being utilized in pediatric intensive care setting, as I said. And even the PALIC 2 guideline has said that for those who are ventilated non-invasively, not on the invasive mechanical ventilation, those who are on non-invasive mechanical ventilation, the SF ratio is used to diagnose as well as to stratify the severity of mild, moderate, and severe variety of ARDS. So that there's already established. So extrapolating that to the VV children in pediatric emergency was a good attempt, and I will say that SF being a non-invasive, it is readily available, and if it correlates well, like 97% of sensitivity in this particular study, so that will probably obviates the need for doing a frequent blood gas or that attempt of getting PaO2 and pricking and getting an ABC in a child who is already irritable, in distress and wheezing. So SF can be utilized, but there are certain literature studies which have shown that the correlation between the PF and SF may or may not be them. This is a very varied data. It's not very uniform. There are studies which have shown a good correlation, and there are studies which have shown a very varied correlation. So how SF and PF correlates, that is still not very clear. The one more limitation which I found in this study was that the SpO2 was measured on admission, and ABG was done almost after half an hour. So in that half an hour, the child would have got nebulization, child would have got oxygen, and probably that will reflect in your PaO2 values and will probably alter the PF ratio or the PF data. So that was one limitation. But overall, it is a good attempt, and what the study adds is that it can be explored, the SF ratio can be utilized as a non-invasive screening tool in pediatric emergency setting and can be utilized to predict the PSO admission. But yeah, we need a larger study, maybe a multicentric, to conclude and to probably implicate the same in your clinical practice.
Correct. So I think the ABG which was done, they have written is within 30 minutes, and probably in a busy ER that is more realistic. Usually in public hospital, when a lot of patients are there, simultaneously in our hospital also nebulization is going on. So obviously there is a time gap is expected, and probably that is why it is there. So what it tells basically, I think, is that because the sensitivity of the SF ratio was found to be very high. So probably it's a good diagnostic test of for need of intensive care admission. And on the other hand, the PaO2 FiO2 ratio had a good sensitivity, so probably good specificity, largest specificity. That is more of a good screening test. And the very fact that you told that the SF ratio is already there in the guidelines of the ARDS recently published ARDS guidelines. So I think more studies will come on, especially, and it is very, because in busy ER very often we find that some or other patient when is sent off from the ER comes back, and that is what with more sickness, and that is what we want to prevent in our public hospitals which are of high load, very high load. So I think we are already short of time, so I'll straight away go to our postgraduate, Dr. Divya. Are you posted? Do you have a separate pediatric ER at your place, or it's a combined adult ER along with the pediatric ER?
No, sir, we have a separate PICU, sir.
That's good.
The government and the private setup. So there are two separate ICU exposures that we usually have.
No, I'm asking about emergency.
No, it's a separate ER, sir. Pediatric ER is
separate ER. So you have been posted in the ER, I believe. So you get wheezy children. So what do you do how do you decide that after, say, in wheezy children or in patients who need, currently, what is your practice? How do you decide which patient should go to PICU, which patient should go to ward? what parameters you are currently looking at?
Usually when we get a child to ER, we first look at the vitals. So if the child is, say, severely tachypneic, or if the child is having increased accessory muscles of which is being used with subcostal or intercostal retractions, and if the saturation is not being maintained, if the child is very lethargic, or if the child is having significant poor oral intake, if these few parameters are there, then requiring continuous monitoring. Along with that, if there are certain defining auscultatory findings, if say the child is having significant amount of wheeze and mainly the saturation and accessory use of muscles, then we admit the child in PICU. We usually give like back-to-back nebulizations in casualty. Then we put on a basic support like nasal prongs or something, and then shift the child to PICU. There we again decide based on mainly we do an ABG, baseline ABG, if saturation is an issue.
Currently, do you objective criteria? So currently, are you using any objective criteria that after doing the nebulizations, what parameters you would be using to shift the patient to PICU? I mean, that is what the study addresses.
Right. So after doing usually after giving nebulizations, actually right now we don't do an ABG in ER. That is not being done, sir. So as an objective thing, it's usually only a subjective finding based on the literature. Yeah.
So just one comment here. So
Yeah.
in a child who is wheezing and we are doing initial intervention, by and large, we allow the child to stabilize this, see the response. Doing an ABG or PA2, it should not be the standard practice and should not be the message conveyed to the audience over here.
Yeah.
And getting the SF ratio, which is more non-invasive. Yes, that can be done, that can be studied, but jumping onto ABG, even in your study, you said half an hour, but for maybe having that is also a little too much because sometimes it gets delayed, sometimes maybe 45 minutes, 1 hour, because you are doing some intervention, allowing child to take some time and get stabilized in the ER rather than jumping and getting a blood gas jump.
Correct. So just to again clarify, so the patient who have already responded to therapy, ABG definitely is not needed. It's only after 3 nebulizations and other clinical parameters are demanding, then only blood gas needs to be done. So
I had one query on this. How in ER do you know the FiO2? So every patient who is given oxygen is not by a machine which gives a fractional index of oxygen which we are delivering.
So
especially in the ER. In NICU we have blenders to give oxygen. So in ER, I wonder how
in the methods the authors have mentioned, I think Dr. Mandar can elaborate. So they have mentioned that once the oxygen is given with nasal cannula, so at 1 liter the FiO2 would be around 24, 2 liters 28, 3 liters 32, and 4 liters 36. And with the mask also, I think they have mentioned. Dr. Mandar can elaborate.
Yeah, it is mentioned. So the simple oxygen mask, 35 to 60%, flow rate of 6 to 10 liters per minute. And then with every liter increase in the oxygen flow, the FiO2 increases by 10%. And the same for the nasal cannula, that's a standard formula, sir. So 21% plus 3 into the flow rate. That is what the FiO2 is being delivered. Suppose the patient is on 2 liters. So that will be 21% plus 3 into 2, that is 6. So almost around 27% the nasal prongs will deliver if the child is on 3 liters per minute. If the venturi is being used, then that is standard. And if you are using non-rebreathing mask, it will be considered around 98 to 100%. So in this study for non-rebreathing mask, they have with reservoir bag, they have considered it as 100%.
Wonderful. So this is an important take-home message. Till now, I was also under impression that only preterm babies who are on risk of oxygen, they require blenders or measurement of FiO2. But it's a good sight to know that older patients also you can just monitor and how much FiO2 we are giving, even in non-ventilated or on CPAP or BiPAP as they use in older children. Thank you very much.
Thank you. So we are already just too much over time. So I think I'll hand over Dr. Amit for the third article.
Yeah, the third article is actually very interesting one. It was an eye-opener for me as well. We have this ART law which has come into. ART is very closely associated with neonatology, so it is of special interest to us. And I was really quite surprised to know through this article that for every 1,000 live births, risk of short-term health concerns are 2 with natural conception, but 5 with ART. And if it is 4 in natural twins, then double the risk. 9 is with ART twins. So, and this is especially so for if more than one embryo transplantation is done. So one message which comes out from this paper is that single embryo transfer implantation is better for the health issues which the baby may have as compared to multiple, at times 2, at times 3 or 4 embryos are transferred to increase the success rate for your IVF center. So that is something which, and at times, many times, not at times, but many times, reduction has to be is done at later gestation from triplets or quadruplets to twins. And so this is important. Many double the non-chromosomal birth defects also double with the population, with the ICSI. So we have an author with us, Dr. Mamta Gowda, to tell us about the new act which has come over in brief on this ART. 2021, we had a new act which was actually required. So over to ma'am for telling us about the new act and how does
Thank you
it
so much for
start?
that. Yes, sir. I'll share my screen, sir. Yeah. So, yeah, the article was drafted by myself, who is an obstetrician and kind of clinical geneticist
We
who's
are very
involved in
happy to
prenatal
have an
diagnosis.
interdepartmental meet.
Yeah.
I think
Yes, sir.
Dr. Vijay, it's for the first time that we are having a
Yeah,
obstetric
yeah.
colleague
Yeah,
over
and I
here in 2.5 years. So we have been very post-dated on this.
Thank you so much, sir. I'm more involved in prenatal diagnosis and therapy, and Dr. Babiti is our pediatrician here, and Dr. Kubera is an infertility specialist. So we have taken inputs from like all three of us sat together and drafted this. So we started with like introduction of the problem of infertility, how prevalent it is, and how the growth of infertility treatment happened in India. With like initially it was 1978 in the globally with the birth of Louis Brown, and in India the first birth happened in 1981, which is not much far from what happened globally. The problem is that with the growth of ART treatment, there has not been a proper regulation introduced. Especially this is true globally, not just in India. And though UK was the first one to introduce some of the regulations, ICMR in India also tried to introduce some regulation, but since they were not well drafted, not very effective. So this was a long-awaited act which everyone wanted to be implemented. And finally, the government has taken a decision to pass this act in 2021. And how it has impacted clinicians and the infertile couple is yet to be seen. And this act, we have covered, along with the ART Act, we have also covered Surrogacy Act because they go hand in hand. The same clinic which are offering ART also offers surrogacy. So it's we thought it is appropriate to discuss both these acts. And both these acts are also interconnected to PCPNDT Act because there is a provision to do sex determination and of course females we decide with these acts. So they have to be interpreted in connection with PCPNDT Act. So we divided issues into like what could interest the pediatrician rather than the obstetricians and the infertility specialists per se. So we started with addressing the general issues and controversies. As we all know that it is a very profitable and lucrative practice, infertility. You can see infertility clinic everywhere, mushrooming in all over in India. Though ours is a very densely populated country, it is a misconception that we don't need, we are not in need of infertility treatment. Despite being one of the most populous nation, we do have very flourishing infertility practice. And most of this, as such, were very unregulated and leading to a lot of unethical practices and which could affect the safeguarding of the children as well as exploitation of the infertile couple. for lucrative business for the infertile, for the clinicians. It can be other way also. Patients can also be exploiting the clinician. So it's kind of more of a business model that is existing in India. So, however, with the introduction of this act, the act has made the treatment to be altruistic. It will not be made for commercial purposes. So even women or couple who are men who are donating their gametes and who are donating their womb for surrogacy will not be paid any remuneration. Only their health insurance will be covered and nobody will be coerced into becoming the donors. Previously, it was very prevalent that family members, somebody who is widowed or somebody who is unmarried or whoever is vulnerable woman can be coerced into becoming a surrogate mother. These things have been taken care of as a general issue in this act. Then we have covered about the ethical and moral issues surrounding that. This is one of the most important issue surrounding the infertility treatment. So the Act provides for doing the pre-implantation diagnosis and genetic screening. However, these might be used for making designer babies and eugenics, selecting only those which can be of desired traits. This used to be prevalent, but now this has been cut down by introduction in the act that genetic testing will be done only if there is an affected proband or if there is a family history. I mean, they are at risk of having a genetic disorder. Only for those known genetic disorders, pre-implantation genetic diagnosis has to be done. And another concern that was there was sex selection. So as we know, this is a male predominant country, so males are usually preferred. And this is a problem with even PCPNDT Act has not been able to tackle effectively. And ART Act connects this act with PCPNDT Act and prohibits any sex selection during ART procedures. And one more concern that was there is savior sibling, that we do come across patients who want to have another child just because the first child is having thalassemia or some other genetic disorders, and the sibling can act as a donor for stem cell transplantation or bone marrow transplantation, things like that. So these have not as such been addressed in the Act, but by providing that genetic testing cannot be done and imposing a lot of restrictions, this also may be tackled. And we thought we'll cover a bit about discrimination towards disabled if we are selecting only the good embryos for transfer. And even genetic testing, this whole section is mostly about pre-implantation diagnosis. So in pre-implantation diagnosis, also the tests are not always very reliable. And one more concern that arises is what happens to those embryos and the gametes which are unused for infertility treatment? How will they be disposed? Things like that. So sometimes they may be used for other patients or it may be used for research purposes. So the Act also imposes restrictions on usage of those embryos for research, and it says that only those embryos which are affected by a genetic disorder and only with the consent of the parents can they be used for research purposes. And some of the clinical issues which Sir was addressing were we divided that section into short-term and long-term health concerns. So most of the articles, most of the literature show that preterm birth, lower birth weight and high perinatal mortality is common in ART procedures. And of course, it is doubled in case if it is multiple gestation, this is even more increased. This could be because of the multiple gestation per se, or because the parents themselves are older and they may be having some health issues which led to the infertility. So all those factors excluded also, it has been shown that these short-term health concerns are increased. And the non-chromosomal birth defects are also double in this, especially the imprinting disorders, because there's a lot of culture media that is being used and the splitting of the embryo, and it is being done outside, it's an in vitro procedure. So many things might be introduced which increases the birth defects and also growth problems. So they can be overweight as well as underweight too. If they have bequeathed men, of course they will be overweight. So these are some of the short-term concerns. And there was also concern about attention deficit disorder and autism spectrum disorder. So there was a very large study in Canada, which included almost 9,25,000 children, where they studied the ADHD ratio in just infertile people and those who are undergoing treatment. There was a slightly moderately increased risk, but they could not differentiate whether this was from the treatment per se or for the parental factors and multiple births that were common in the infertility. So this issue is still not very much resolved. And there are also links to respiratory disorders. And of course, there were concerns about cancer risk because of the in vitro fertilization, but studies do not show much increase. And regarding the long-term effects, the cognitive effects, there is some concern that there may be a mild increase in the cognitive disability. And there could be increase in long-term cardiovascular and metabolic disorder. So there are many studies, and a large cohort study has not reported any such significant difference. And also fertility issue. This is quite important because if we are treating a person with Klinefelter syndrome or a SRY deletions, and we are using the gametes from the same parent, so that can be the same infertility can be passed on to the male offspring. So this has to be discussed when we are treating such parents. And some of the legal issues are right to parenthood, where as the society, we have this kind of notion that by being married, they become parents, and because the mother has given birth, she is the mother, or because they have donated their biological gametes, they have to become parents. So this used to cause a lot of confusion into who claims to be the parent. So the Act has made it very clear that it is the commissioning couple who are the parents. So even the donors have to relinquish their rights, and surrogate mother, even though she has given birth, she cannot claim to be the mother. And the child also cannot have rights over the properties of these biological parents or by the surrogate parents. So this Act has been very clear about it. And about the co-parcel issues, as I addressed, the property issues. So child cannot claim unless it is the commissioning couple, they cannot claim property rights to biological parents. Same thing with the parents cannot claim rights over the child. However, there is a bit of loophole in this, because the Act doesn't say whether before the Act, whoever were born, are they also eligible for this kind of rights. So this can give rise to some lacuna which lead to friction regarding property issues, things like that. And also about false allegations, the parents, like surrogate mother, for example, after having agreed to the treatment, she may come up later to exploit the commissioning couple, saying that she has been coerced and asking for compensation like that. So these are some of the issues that can be ethical and moral. And before the Act, there used to be a lot of cross-country transfers. The foreign couples, because they have a lot of money, they come to India and they get the surrogacy done, things like that, and they get the donors easily. So now the Act very clearly states that it has to be Indian couple. So it has precluded them from obtaining such cheap treatment in India. So some of the social issues are child trafficking, child being like ART being used to produce children so they can be trafficked and they can be used for illegal activities like that. And a few more issues that we covered were like whether when the child grows up, does he or she have the right to know their origin? So sometimes they may be curious to know who donated, who are their biological parents, who gave birth to them. So in our Act, it says that they can have this information. However, one cannot reveal the identification of the donor or the surrogate. Unless the surrogate or the donor themselves give consent, it cannot be revealed. And one more very important problem is risk of abandonment. Once they have had children, like infertility couple, maybe in future they may have their own biological child, or there may be some differences which may lead to abandonment of the child. So what provisions are there under the Act? So under the Act, it is clearly mentioned that the clinician offering that should give the couples counseling, telling them about the rights of the child and what are the punishment under the provision if the child is abandoned later. So as per our IPC code, the imprisonment is of 7 years or fine is applicable if they abandon the child. And regarding complex family structures, because the Act has now allowed unmarried women also to have children. So that leads to kind of little bit the usual family notions may be altered. So the child upbringing is kind of a concern, but that needs to be seen with the changing societal norms. And there was a request to also include some of the disadvantages of this act. So we thought these 3 points were relevant, though there are a lot of disadvantages with it. Because a single father cannot avail this treatment, though a single mother can. And same-sex couple, though in NHS, UK and other countries, they cannot avail the ART treatment as of now. And unmarried couples cannot avail the treatment. So, as I previously pointed out in the co-parcenary issues, so retrospective implementation of the Act, it is not very clear. So there can be issues regarding the legal heir and the properties. And since it has been made very altruistic volunteering, I mean, who would be ready to donate their womb and become a mother if they're not getting any benefits out of it? So, and also they should not be related to the commissioning couple. So it has become very difficult to procure like volunteering people, altruistic people who are ready to become mothers or donors. So these are some of the things. Maybe there should have been a provision to compensate them as per the government rules, and that has not been provided by the Act. And as per the role of the pediatrician, we thought like pediatricians do not usually come across the couples before preconceptional counseling or before ART procedures are being done. As far as I know, that is a practice, but we recommend that even those who are seeking ART treatment, it's better to refer the couples to the pediatrician, because apart from all the health issues that we mentioned, there is also better judgment by the pediatrician as to are these couples capable of bringing up the child, and are they financially sound, and their attitude towards the childhood, and maybe they can be counseled about what are the issues that may be faced and things like that. So basically, it has to be a collaborative effort, we
The
thought.
last point
Yeah.
was very interesting, ma'am, about the role of pediatrician in this
Yes.
perinatal counseling. And
Yeah.
I, as a pediatrician in practice, just get a call कि doctor हमें there is a cesarean and elective cesarean है, IVF है, आप आ जाइए. Leaking शुरू हो गई है, इसलिए
Yeah.
cesarean कर रहे हैं, आप आ जाइए. And
Yes.
so it's often a last minute call which we get. And if
Yeah.
a very important thing during counseling which should be there is telling the family the information that such IVF pregnancy have more likelihood of having preterm babies. So what we
Yes.
encounter in practice is they go after one IVF with a success rate of 30%. They go after one after the another and another IVF, and they exhaust all their resources. And then if the baby is born twins preterm, then they have no money to look after.
They have no money. Exactly. They have no money. They are completely drained.
If you have allocated this much money for surrogacy, then at least 25% should be reserved for care of that baby, for which you are doing all these things. So
Exactly.
another thing which has to be re-emphasized, you talked about abandonment of the babies, and most common cause of abandonment of baby is a female baby who is born after IVF pregnancy. As
Yes.
many babies who parents who go for IVF treatment, some are infertile, and the other very common group is if you have one or two female babies and then they go for IVF only to have a male baby. So this
Yes.
misconception that fertility can be guided during IVF should also be made very clear. A lot of issues with the obstetrician come up only because say even if not on papers, then during counseling that you will have a male baby.
Yeah.
And that has to be re-emphasized. Now people are doing, because many legal suits have also come over. I've seen in my city as well, a lot of violence also coming over, because they already had two daughters, and IVF there is twins, and again they are both daughters. So, and such babies, such parents, they don't look after their IVF
Yes, sir.
babies also, and they
They
take
will,
the babies from NICU. So
yeah.
this has to be explained to them.
Yeah, and many clinics used to do this while centrifuging because X chromosomes apparently they segregate X and Y, and then they transfer such gametes which have Y like that. So that act clearly says that such procedures should not be used, even genetic
Another
testing for,
query which I
yeah.
had, can, like during surrogacy, what if the
Yes, sir.
surrogate also, has a change of mind and thinks of having, just disappearing during, and then
Yeah,
what is the
yes, sir.
law
Actually,
say about
yes,
that?
exactly. That also
And
little bit
refuses to give
we,
away the baby after birth.
yeah.
So,
No, she just cannot refuse because she has no right over this. But what happens is once she agrees to being a surrogate, she may start exploiting also, or it could be the other way around. Also, because they may say we have some health issues and we need more money, we cannot take care. Those things can happen, and they may abort also anytime. So these things have to be clear before agreeing to the contract. But once the contract is made, uh, but surrogate mother can withdraw her consent anytime until the baby is born. That provision is also there, and including. And one more thing is, if the surrogate mother becomes pregnant and the baby becomes anomalous, then commissioning couples may ask her to abort.
okay.
So that issue also has been addressed, but there is no as such very clarity as to what the clinician's role would be. But apparently once the commissioning has happened, even if the baby is anomalous, like they commissioning couple cannot force the surrogate mother to abort. It has to be like collaborative. She also has to agree. It has to be a mutual consent. And there is no question of surrogate mother not giving the child after birth. Actually, the act has been
Yeah,
ruthless
okay.
in that. In NHS in UK, they allow 6 months of time for the surrogate mother to transfer the rights to the commissioning couple. It has to go through the court, and the court order they have to get, and then take the baby. But in India, the moment the baby is born, they don't even have to wait for breastfeeding. They can straight away take the baby because this contract has happened beforehand. So this is something that is different from other countries like
Yeah,
from
another
UK
problem
and
as
India.
a neonatologist I face is, if a baby is born very preterm and we want to give EBM, and then there is a
Yeah,
conundrum whether the surrogate mother, can she give
yes.
EBM for the baby?
She can.
As a
She can give.
neonatologist, I,
Yeah, she can give. It has to be a mutual understanding between the surrogate and the commissioning. But if
the
there are
risk of
conflicts
having
between
getting
them,
more attachment to the baby is there as well.
exactly, sir. Exactly,
So
sir. That
KMC we
also we had.
provide just by the
Yeah,
by the mother who has to look after the baby, and we
yeah,
admit the baby in the name of baby of. That is another thing. Whom do you
yeah.
admit the baby as, baby of surrogate mother's name, or the mother who will be looking after later on? So we have
Yes,
a
sir.
policy of admitting the baby under the mother's name, who has to look after the baby later on.
Yeah, yeah.
So that is another
So they
thing. Dr.
developed the
Ramesh, I would
bonding.
just like to have a comment of Dr. Ramesh, if he is still there. You also have a IVF center at AIMS, and do you also encounter, if a female child is born out of IVF, then
Once you have, surrogacy now is not that common, but we do have
Yeah,
occasional mothers. It is clear the baby's case file would be made on the name of commissioning parents, not on the
yes.
biological that or donor. So we did have confusion some couple of years ago when this was commissioned, 2021, and that was one occasion, and it was clarified. It has to be on the commissioning parents.
yes. No, do you have encountered when parents don't want to
Your
look after
voice.
the baby if it's a female baby, because for whatever reasons?
No,
And
sorry,
does
say it
the
again.
does the state have any say in a salvageable baby being taken away by the parents because of gender? So, does the state have any say in that? Okay, like we can't give the baby, he's salvageable just because the baby is a female child, and you already have a female, you don't want to get the baby treated. How do you tackle such families?
I don't know whether I understood your question.
So, female, if a female is born out of IVF pregnancy or and parents want to withdraw treatment and take the baby home. So, what does the law say on that? Can you refuse giving the baby to the parents who is salvageable and say no? Withdrawal
no,
of
it's the
support
same.
is
It's the same principles would govern this case. I don't think the IVF case would be any different from
Any different, yes, sir.
so.
Because they are treated as biological children. So it has
yeah.
to be how naturally we are treating.
So yes.
So
So
while
what is your policy on parents want to take the baby home who is salvageable, and just because of say you can perceive it as due to gender bias. So does the state say that you can't take a baby on your own and this is salvageable, or parents' decision is the final decision?
this has been a problem once a while, not very common, maybe once or twice in last 10 years, if I can remember. Overall, not in context to IVF, that the parents are insisting on withdrawal of care and, the child is salvageable. In those cases, we have refused, We simply say that if you wish to leave, then you can leave, but the care cannot be withdrawn. And later, the law takes its own course. Our job is to salvage the child. And if you're not there to discharge or to give, then we call the police. They only will have to sort that issue out. But here the situation in government sector is different because the treatment is totally free of care compared to a private sector where someone has to pay. So the things become more complicated.
Yes.
But
Thank you.
surrogacy has come down a lot now. Hardly any
Drastically.
surrogates being done
Yeah, yeah.
after
Hardly
this
any
success.
surrogacy now.
Hardly any.
Hardly any
Centers have closed
surrogacy.
down. In Gujarat, there were
Yes,
many
exactly.
centers which were there, and they have now closed down and become a multi-specialty hospital from being a purely obstetric center. So I know many
Yeah,
friends of mine who were neonatologists there. They have shifted over because these obstetric centers have turned into multi-specialty hospitals.
Yeah, 5-7
Dr.
years.
Mamta? Sorry. Dr. Mamta, there is a query from my side.
Yes, sir.
We have cancer
Yes.
kids, and they are, when we put them on chemotherapy, we counsel, especially adolescents, about fertility issues. And there is a provision for cryopreservation of the ovum. So what is the
Yes.
lifespan and what are the outcomes with those kind of
Yeah.
efforts that you put in?
Yeah, actually, cryopreservation can be done as per the law also. For up to 10 years, it can be preserved. The gametes and even the embryos. Even we have covered little bit touched upon this with regard to the deceased husband has died, things like that. Or husband is suffering from husband or wife is suffering from a serious health concern, in which case we preserve this gametes. Usually under this law, it is said that up to 10 years it can be preserved. But as you are saying, in children, if we are doing that, there is no clear indications. Maybe after 10 years, they may have to reapply, and whether it can be preserved for a longer time. And as per the results, cryopreserved has not shown much difference from fresh embryo transfer. In fact, the results all over the globally is much better for a frozen and thawed embryo than a fresh one. That might come as a surprise, but that is what most of the studies have shown.
How much would this cost?
Cryopreservation.
Yeah.
Cost, I think it is, I have no idea about the cost, but I think it's the yearly they have to keep paying until disposal, something like that. But not many centers are doing this, so I'm not very sure how much they're charging. As such, for each IVF cycles, it can range from 80 to 1 lakh. And I guess it will be around like cryopreservation for 2 to 10 years. They may charge anything between 2 to 3 lakhs, I feel. But
Thanks
I'm
so
not
much.
sure about this cost. Yeah.
Thanks.
I can find out from my infertility friends. And
Okay, great. So over to you, Dr. Pooja, to
So thank you so much to Dr. Ramesh, Dr. Jandar, Dr. Mamta and Divya for a very interactive session, and we definitely exceeded our time today. But all the same, it was engrossing and we had a nice interaction with all of you. So before we close this, I just wanted to apprise that we had another article in this issue on which is very relevant to all of us, is regarding the update in definitions, WHO cutoffs for anemia. So over the years, developing countries have been arguing that the cutoffs need not be the same for West and developing countries because the references should vary. So some change has been there in the cutoffs in children. And now instead of having a broad cutoff of 6 to 5 years, the cutoffs have been revised for 6 to 23 months and again from 23 to 60 months. And the cutoff has been lowered by 0.5. So instead of going with an 11 cutoff for defining anemia, it's 10.5. And this is based on the emergence of data from multiple systematic reviews and individual studies where they have shown that anemia should be defined in less than 2 years kids by a cutoff of 10.5 instead of 11. There are issues that still remain regarding, defining in the presence of infection or in the presence of inflammation. These cutoffs would again warrant some change, but we don't have any evidence as of now. Another thing that has changed is with respect to the pregnant women. And now in the second trimester, the cutoff is again 10.5 instead of 11. So that's a change. High altitude changes, we all know that with higher altitudes, polycythemia is there. Again, the cutoffs have been revised. Depending on where you are staying, the elevation varying from 500 meters to up to 5 kilometers. So you can go back to the journal and read through this important update. And there are lots of other articles as well. There's an article on bisphenol detection in breastfeeding babies. So we do have more articles. Please go back and have a read. And I would like to now conclude this session with thank you to all the panelists and our moderators, Dr. Amit and Dr. Abhijit, for a very nice and interactive session on this Sunday morning. So
when is the next session, ma'am?
it's scheduled next month. A tentative date is 28th, but we'll get back again on this soon.
Okay. The fourth Sunday, 10 a.m. we meet again.
So
Thank
it's
you.
generally the last Sunday. And
Yes.
thank you again so much for
thank
joining.
you so much.
Thank you, Dr. Ramesh.
Thank you, everyone.
Thank you.
Bye-bye.
Bye-bye.